Mitral regurgitation. Use of color flow Doppler controls. Mitral regurgitation during systole can be seen by color flow Doppler in the left atrium using color flow Doppler. One serious problem for color flow Doppler is the fact that improper use of the color controls can result in a marked increase or sometimes decrease in jet size. Multiple factors can control this creation of a spuriously sized jet and profoundly affect the estimation of jet severity. Use of color gain. The first and most obvious control is that of overall color gain. On the left panel of the screen, the normal color gain is demonstrated. The right panel shows a remarkable increase in the overall color gain resulting in a somewhat larger jet when color gain is increased. In this video segment, the dynamic effect of variable color Doppler gain is shown. First, the color gain is set too low. By increasing the color gain, we get correct gain parameter. And after increasing the color gain even more, we get obvious excessive color Doppler gain. Excessive color gain is characterized by the sparkling appearance of a variety of pixels. The hallmark of correct gain is the detection of some low velocity flow in the left ventricular outflow tract as well as lower velocity flows seen surrounding the turbulent jet. The lower velocity flows surrounding the turbulent jet reflect the movement of red cells already present in the left atrium that are engaged by the regurgitation. This phenomenon is known as the entrainment. Altered Nyquist, or scale factor. Another major factor that can significantly alter the size of the color jet is Nyquist shift. By lowering the Nyquist, or color scale factor, progressively lower velocities will be displayed with increased brightness, artifactually increasing jet size. For the display of color flow images of mitral regurgitation from the apical four-chamber view, most international standards recommend scale factor, or Nyquist settings, in the 60 centimeters per second range. Effect of frame rate. In this video segment, the effect of decreased frame rate is shown when a moving jet is encountered. Low frame rates may increase the size of a mitral regurgitant jet. Obviously, the maximum temporal sampling that is possible will provide a truer depiction of dynamic jet size. One should completely avoid widening the color flow sector arc, thus slowing frame rate and obscuring flow dynamics. Effect of persistence. Color frames obtained over a period of time could potentially be added to one another in any given display using a control called persistence. The addition of multiple frames in a moving image could result in a markedly increased jet size. Neither two-dimensional echo images nor color persistence should be used in echocardiography. Excess image gain. It is also possible to decrease jet size with certain setting factors. One could decrease the jet size with excess image gain. The added image gain encroaches on pixels occupied by color and the color is eliminated. This happens because an image display can provide a picture of either black and white anatomic information or color flow information, but not both at the same time. By increasing the image gain, low amplitude image noise into the picture is increased, which causes a haze within the cardiac chambers, displacing low velocity flow previously detected with optimal image gain. Therefore, excess image gain as well as color gain should be avoided in the conduct of any color flow examination. Doppler methods for grading MR severity. We advise that a beginner should always try to avoid the use of hyphenated degrees of mitral regurgitation, such as mild moderate or moderate severe. While it is accepted that such borderline degrees may actually occur, a simple grading system of none, trivial, mild, moderate, or severe is preferred, or 0, 1 plus, 2 plus, 3 plus, or 4 plus. Echocardiography takes discipline and practice in order to use every tool available in achieving a reliable clinical diagnosis. Color flow Doppler parameters. Color flow Doppler imaging is perhaps the most intuitive of all measures. It is useful for detecting the jet origin, direction, and spatial relationships, and has excellent sensitivity and specificity. Each of the three components of the MR jet, flow convergence zone, vena contracta, and jet profile, can provide a semi-quantitative or quantitative measure of MR severity. MR jets are best assessed using multiple windows to obtain a three-dimensional perspective. Qualitative estimates of MR jets are categorized on a scale of 0 through 4. Grade 0 indicates none or trace MR, and grade 1 through grade 4 indicate mild to severe MR. The notation 1 plus, 2 plus, and so on to denote increasing grades of MR severity is also commonly used. Color jet area. The color jet profiles can be measured within the left atrium. Color jet areas are influenced by jet velocity, momentum, and direction. Mild MR jets cover less than 20% of total left atrium area, or a maximal jet area of less than 4 centimeters squared. On the other hand, severe MR jets cover more than 40% of total left atrium area, or a maximal jet area of more than 10 centimeters squared. At least two orthogonal views should be used with the Nyquist limit set at around 60 centimeters per second. Large colored jet areas indicate more severe MR when the jet is centrally directed, but the results of the measurement can be misleading with eccentrically directed jets. Hugging or entrainment, which is also called the Coanda effect, of the eccentric jet to the left atrium wall results in smaller jet areas even when MR is severe. In acute MR, even centrally directed jets may be misleadingly small. A small non-dilated atrium in the setting of acute regurgitation constrains the regurgitant jet momentum and hence the visible color jet area. First, one measures the color jet area in parasternal long-axis view. Then one measures the area of LA in the same view. And then one calculates the percent of total LA area. Patient E with mild MR. The jet area around 3 centimeters squared. The LA area around 30 centimeters squared. The jet area is 10% of total LA area. One measures colored jet area in 4-chamber view. One measures the area of LA in the same view. And then one calculates the percent of total LA area. Patient E with mild MR. The jet area is 3.6 centimeters squared. The LA area is 29 centimeters squared. The jet area is 12% of total LA area. Patient A with moderate MR. The jet area is 9 centimeters squared. The LA area is around 45 centimeters squared. The jet area is 20% of total LA area. The jet area is around 12 centimeters squared. The LA area is around 40 centimeters squared. The jet area is 30% of total LA area. Patient B with severe MR. The jet area is around 13 centimeters squared. Note the Coanda effect. The LA area is around 42 centimeters squared. The jet area is 31% of total LA area. The jet area is around 17 centimeters squared. The LA area is around 41 centimeters squared. The jet area is 42% of total LA area. Vena contracta width. The vena contracta is the narrow neck of the MR jet as it traverses the regurgitant orifice. The vena contracta, measured from the parasternal long-axis view, is best optimized by using a narrow sector scan, optimal color gain, and Nyquist limit between 40 and 70 centimeters per second. The vena contracta appears as the well-defined light blue or light yellow high-velocity core on the red-blue color Doppler scale. This portion of the regurgitant jet, unlike the flow convergence zone and the distal turbulent jet profile, most closely mirrors that of the actual regurgitant orifice. Therefore, it is a more reliable marker of MR severity with significant advantages over other methods provided that the recommended technique is used. A single vena contracta width measurement, however, is a two-dimensional snapshot across an elongated regurgitant orifice area. It is recommended to average vena contracta width over at least 3 beats and to use 2 orthogonal planes. A vena contracta width less than 0.3 centimeters indicates mild MR. A vena contracta width more than 0.7 centimeters indicates severe regurgitation. Vena contracta width measurements are not valid for assessing MR severity with multiple MR jets. The measuring of vena contracta width in parasternal long axis view. Patient E with mild MR. Vena contracta width is 0.25 centimeters. The measuring of vena contracta width in 4-chamber view. Vena contracta width is 0.24 centimeters. Patient A with moderate MR. Vena contracta width is 0.38 centimeters. Vena contracta width is 0.38 centimeters. Patient B with severe MR. Vena contracta width is 0.9 centimeters. Vena contracta width is around 1 centimeter. Proximal flow convergence and proximal isovelocity surface area, or PISA. This method can be used for estimating the area of the regurgitant orifice, which is usually hard to measure directly because actual regurgitant orifice is dynamic, functional, and three-dimensional. As regurgitant blood converges toward the regurgitant orifice at the proximal convergence zone, the size and velocity of the innermost shell or hemisphere can be measured. Furthermore, according to the continuity principle, the amount of fluid that passes through the regurgitant orifice is the same amount that flows in the regurgitant jet. Therefore, total flow at the proximal isovelocity surface area, or PISA, will equal total flow in the distal MR jet. The apical 4-chamber view is recommended for optimal visualization of the MR jet PISA measurement. The area of interest is optimized by lowering imaging depth and lowering the Nyquist limit on the color Doppler scale to approximately 40 centimeters per second. The velocity at which the blue-red color shift occurs identifies the PISA shell. The PISA radius is then measured and multiplied by the PISA velocity, also known as the aliasing velocity, to give the regurgitant flow rate. From this, the effective regurgitant orifice area can be calculated using the continuity principle equation for flow rate. The maximal velocity is the peak velocity of the MR jet on the continuous wave Doppler. It should be noted that the PISA method makes several assumptions, many of which could be violated in the clinical setting. Patient E with mild MR. PISA radius is 0.3 centimeters and regurgitant flow rate is around 21 milliliters per second. Maximal velocity is 3.9 meters per second. Effective regurgitant orifice area, 0.05 centimeters squared. The grading of mitral regurgitation according to effective regurgitant orifice area. Patient C with moderate MR. PISA radius is 0.61 centimeters and the regurgitant flow rate around 98 milliliters per second. Maximal velocity is around 4.7 meters per second. Effective regurgitant orifice area, 0.21 centimeters squared. Patient D with moderate MR. PISA radius is around 0.8 centimeters and the regurgitant flow rate around 160 milliliters per second. Maximal velocity around 4.8 meters per second. Effective regurgitant orifice area is 0.34 centimeters squared. Patient B with severe MR. PISA radius is around 0.8 centimeters and regurgitant flow rate around 155 milliliters per second. Maximal velocity around 4 meters per second. Effective regurgitant orifice area is 0.4 centimeters squared. Other Doppler methods. Systolic flow reversal in the pulmonary veins. The presence and the degree of blood flow reversal from the left atrium into the pulmonary veins can indicate the hemodynamic impact of the MR jet. Visualization of flow reversal into one or more pulmonary veins on the color flow Doppler, or more reliably, pulse Doppler evidence of flow reversal into the pulmonary veins, are measures of MR severity. In normal individuals, a positive systolic wave followed by a smaller positive diastolic wave is seen, but with moderate or severe MR, blunting or reversal of this pattern can be seen. Systolic flow reversal may be indicative of severe MR even if the color jet area suggests a milder disease. Blunting of pulmonary forward flow may lack specificity, but is nonetheless a useful parameter that provides information independent from color Doppler methods used to assess MR severity. Patient E with mild MR. The pulse Doppler spectral flow profile is normal. Patient C with moderate MR. The blunting of pulmonary vein systolic flow. Patient B with severe MR. Pulmonary vein systolic flow reversal. Continuous wave, jet intensity, and morphology. Peak MR jet velocities by continuous wave Doppler typically range between 4 and 6 meters per second, a reflection of the systolic pressure gradient between left ventricle and left atrium. If the blood pressure at the time of the study is low, the peak velocities and gradients will also be low. Therefore, peak MR jet velocities alone are not reliable measures of MR severity. There are some spectral Doppler findings which may assist an examiner in determining the severity of regurgitation. The method for determining the severity of mitral regurgitation using spectral Doppler relies on the subtle comparison of diastolic flow, seen above the baseline, to the regurgitant systolic flow seen below the baseline in brightness. Simply expressed, the brightness of any Doppler signal reflects the number of red blood cells moving through a Doppler sample if spectral Doppler gain settings are properly set.